Thank you, Dr. Nader. I will be talking today about the cataract surgery and pseudoexfoliation syndrome. First, what is pseudoexfoliation syndrome? It's a systemic multifactorial disease, age-related of the elastic fiber structure, where we can find excessive production and deposition of fibrillar material, both inside the eye and outside the eye. So in the eye, they are deposited on the lens capsule, the zonules, ciliary epithelium, also on the iris pigment epithelium and trabecular meshwork. And the picture on the right side, you can see these fibrillar material are present inside the eye, and this is a classical picture of a pseudoexfoliation syndrome we can see in our clinic maybe every day or every other day. This is considered an ocular phase of systemic disease. So it is a systemic disease where this material is also deposited outside the eye in the skin and the visceral organs. And sometimes these patients suffer also from hearing loss and cardiovascular disorders. So we may consider that these patients, if we see them in our clinic, to be referred to a cardiologist or ENT specialist if they have any problem concerning these systems. Who develops PXF? This is more common in older patients. Females are more common. However, recent studies may suggest that males also can be affected as equal as females. It is often unilateral. It is asymmetric if it comes in both eyes. And the pictures on your right show the same patient with one eye having pseudoexfoliation and the other eye is completely normal. So it's almost always either unilateral or maybe asymmetric. At a later stage, the other eye may develop the same condition as the first eye. It is very important to diagnose in pseudoexfoliation because up to 44% and maybe more of eyes show raised IOP, and this is the most common identifiable cause of secondary open-angle glaucoma. In pseudoexfoliation syndrome, there are three pathologies we should anticipate. First of them is zonule disease. The second is iridopathy. The third is endothelial cell abnormality. The zonules are very weak due to proteolytic disintegration, which may cause problems in our cataract surgery, like lens instability and posterior capsular rupture with vitreous loss. Even we can be confronted with dropped nucleus if the zonules are very weak and involving the 360 degrees all around the zonules. The deposition of this material in the iris causes poor dilatation of the iris during surgery with mechanical rigidity, and even during the surgery we can be confronted with sudden interrupted meiosis. What about the endothelium? The endothelium is less in endothelial cell count with abnormal size and shape, altered morphology. So we can expect in these cases post-operative corneal edema and even risk of decompensation if the endothelial cells are much affected. How dangerous is the PXF in our operating theater if we are doing cataract surgery? They carry much higher risk than normal eyes in terms of all these items to your left, in terms of IOP increase, the PCR posterior capsular rupture, and nucleus drop. We can convert to ECC in about 2.6 more patients than the normal eyes. Zonular adhesions in terms of 7% more, and IOL dislocation that needs surgery in about even 7% or even 7 more than the normal eyes. So there is a high risk of cataract surgery in these patients. And even this number can show this in a more evident way. And there are some parameters that we look at in these patients that may increase the risk during the surgery, like poor mydriasis. It carries a 4.8 higher odds of zonular complications. If it is associated with the shallow anterior chamber, it raises the risk to 24 times more. And if we can notice lens disintegration, we can see the number is 287 more risk than the normal population. So these patients carry high risk of complications, but they have favorable outcomes only with early recognition and proper management, we can achieve visual outcomes which are still favorable. Very important thing to identify and diagnose the pseudoexfoliation during the examination. So we have to put proper mydriatics. We have to dilate the pupil very well so we can see the changes that are seen here in the picture and what we call the double ring sign. What is double ring sign? There is a central ring of fibril deposition and then a clear zone which coincides to the movement of the iris, and then a peripheral outer zone which is directly related to the zonules. And there is some studies that suggest that the density of the deposition of the fibril material in this area may denote zonular weakness more than the others. In also the examination, we have to examine the cataract, density of the cataract. Typically, this dense nucleus comes in old age. It comes in a higher density than normal. And we can look also for lens subluxation, what we call phacodonesis, by doing saccadic eye movements. Let the patient moves the eye to the right and the left, and we observe the anterior chamber depth. And very important sign that in the anterior chamber depth, then we cannot appreciate the anterior chamber depth while the patient is supine. So if suspect pseudoexfoliation and suspect phacodonesis, we may resort to making the patient lying down, and we observe his anterior chamber depth. We can see there is abnormal depth or irregular depth during lying supine. Of course, we can measure the intraocular pressure, optic nerve evaluation for detection of glaucoma. And we can also do gonioscopy where we can see what's called Sampolozzi line, which is a pigmentation anterior to the Schwalb's line. And very important investigations, I usually don't do it a routine in cataract surgery or before cataract surgery, is specular macroscopy to examine the endothelial cell counts and be prepared for the management of this condition if it occurs. A very important thing to note that the absence of phacodonesis, if you cannot see the lens subluxate during examination, this does not mean that there is no zonular weakness. So we can almost always anticipate there is zonular weakness even if you cannot detect subluxation of lens during initial examination. So there are some warning signs that we should look for and be aware of, like phacodonesis, asymmetric anterior chamber depth, the fibril deposits and the scalloped lens edge, the poor pupil dilatation, and the pigment in the angle. In this patient, you might like to counsel and talk to the patient before you doing surgery. Counseling involves advised early surgery and discuss the difficulties and the outcomes that you may have after surgery. First of all, in the surgery, you have to do maximize pupil dilatation. It's a very important step to prescribe preoperative non-steroidal anti-inflammatory before surgery to keep the pupil as much as you can dilated during the surgery. And what you can have from mydriatic drops, intracameral adrenaline, use cohesive OVD. Viscomydriase can maintain the pupil as a sufficient diameter, use soft shell technique, and always prepare your expansion devices as iris hooks or Malyogen ring. Expect always ocular laxity. When you are doing capsulorhexis, you can always look at the anterior lens capsule. You can here note in this patient, in this eye, some wrinkling of the anterior lens capsule with capsulorhexis. This denotes there is some weakness of the zonules at this area. Always make a large capsulorhexis, 5.5 even. I don't like to enlarge it to 6 in case of I needed optic capture later on. 5.5 is fine, I think. It simplifies the extraction of the nucleus and reduces the potential for future capsular phimosis. During hydrosection, it differs whether the lens is a little bit subluxated or there is high suspicion of zonular weakness. If so, try to make limited hydrosection. If you are sure enough, do thorough hydrosection, but gentle. Always use phaco, slow phaco. It's better to use slow stop and shop phaco. You can use also divide and conquer if you are sure that the nerves are okay, but stop and shop is preferable. And remove OVD thoroughly after you complete your examination. Even some studies suggest that you can irrigate the anterior chamber angle at the end to clear the material, the PXF material that may cause trabeculitis or increase the intraocular pressure. The choice of IOL, this is a debate what to choose. You can choose aspheric IOLs, toric IOL, multifocal IOLs, because of the capsular bang on the long term is liable to decentration. So lenses that are not performing very well with decentration, we can avoid, but this is still a point of debate. The capsule supports always prepare yourself for iris hooks or Malugin ring. You can also prepare yourself for capsule hooks, capsule tension ring, capsule tension segment. These all should be tools prepared if needed during the surgery. You must be very flexible during the surgery. You must expect complications at all times, and you must be prepared. Also, the CTR, of course, place it as late as possible, but as early as you need it. And this is maybe the most common tool you will need in such cases. Always be flexible and be prepared. You can convert at any time to extracapsular. You can need anterior vitrectomy. You can enlarge the capsular axis. You can alternate oil fixation. You may need scleral fixation or other fixation. I think this is a surgery, a condition that tests the skills of the cataract surgeon, because you are liable to confront all types of maneuvers or techniques. So you have to be familiar with all of these techniques, and this is a condition that tests the skills of the cataract surgeon. Even for follow-up, post-operatively, it is very important to do long-term follow-up with IOP monitoring. And always in your follow-up visits, dilate the patient. Why? Because there is a high incidence of capsular phimosis. You want to detect this early, because if it occurs, you want to do like YAG laser anterior capsulotomy, enlarge the anterior capsule to prevent decentration or even tilt of the IOL. You can face progressive zonulopathy over time and even IOL dislocation. So you have to always dilate your patients in follow-up. So the take-home message: PXF is a technical difficulty with high complication rates, but excellent visual outcomes are achievable with preparation and proper technique. Identify early, plan and adapt, and be flexible, and stay controlled. Thank you very much.
Thank you very much, Dr. Hazem, for this excellent presentation.